Hi, so I'm Sturdy McKee. I'm a business coach and advisor. I have a background in physical therapy, owning practices and running them and that, but I've been doing full-time business advising and coaching for the past 5 years or so. And a lot of mentorship and teaching and coaching and speaking and stuff before that. But I'm here and really thankful, Pauline, thanks for hosting with the GMR Web Team to help you with reduction of cancellations and no-shows. And let's get into it. You can download this handout, and there are a couple exercises and things for you to do. Just go ahead and type that URL into your browser. It is case sensitive, so that's been an issue sometimes in the past. Make sure you type it in just like that, case sensitive, GMR Sturdy, the GMR and S capitalized, and the 2, and then you'll get a Google Doc that you can either print, download, or create your own copy that you can own and work alongside what some of the things we're doing, and then have a worksheet to look at what the benefits and stuff would be later. So you can communicate that with your team and your staff. Let me know if you want me to pause on that for a second, or I'll go back to it if need be. So in our practices, in the healthcare businesses industry, there are 3 kind of big challenges that we are all dealing with, no matter what your background or specialty is. And payers and payment obviously is one. You know, if you're at a cocktail party with a bunch of healthcare providers and you start bringing that up, you just can step back and let the conversation keep going, right? Hiring great staff is always a challenge too, and then acquiring and keeping patients. So we're going to talk about the acquisition and the keeping of patients today. So marketing. Marketing is all the external stuff you do, and sometimes it gets a bad rap. I don't think it should. I work with a lot of physical therapists, and I tell them that PT is the best kept secret in healthcare, and it's because they don't do a great job of this. And it doesn't have to be, I think, what some of the connotations are and some of our first impressions might be with advertising and all that kind of stuff, but just education, letting people know what you do, how you do it, how you can benefit them, what's in it for them. That helps you to generate leads. And for a little bit more on that, go back to session 1 that we did with GMR, and basically between Pauline's webinars and mine, you're going to learn that most of what you know about marketing is not right. Okay, so and it ends up being a lot simpler for you. But this is really about lead generation. Then we get into sales. And this is kind of how we all feel about sales, right? I love this slide because I found this, and it just makes me laugh every time. But when we're selling, and that's a bad word, for a lot of healthcare providers, but selling is simply trying to get people to do what's in their own best interest. We're not trying to have them do something that's not in their best interest. We're not trying to convince them of something they don't need. And that's a lot of times the connotation. And what we're really trying to do is get buy-in from them on the things they do need. So not only is it not bad, but you almost have an ethical obligation to learn how to sell more effectively and make sure that you get buy-in from your patients. So what's the difference between sales and marketing? So, that those two get convoluted or bunched up all the time. I even saw a thing on an entrepreneur group of 1,500 members or something where they talked about marketing and then everything was about conversion. It's like, no. Marketing is lead generation. Marketing creates interest and brings in leads, people who are interested in your business. Sales converts those leads into paying customers. These are 2 distinct processes, okay? So we need to convert in order to be effective. So if we can do the marketing, we can generate leads, we can generate interest. If we're not converting, that it doesn't work. So what does conversion mean? Means converting inbound leads into paying customers, okay? Or patients or clients, or however you want to phrase that. But ultimately, the people who are going to help cover your costs and pay your bills, right? What are inbound leads? Anybody, okay? When I say anybody, I mean anybody inquiring about your services. And every time I do a big in-person talk, somebody has to say, well, what about this? Yes, anybody, absolutely anybody. Okay, so if they're interested in your service and they contact you, and for some of you, that's a telephone in the second picture there. But schedule an appointment, whether they're doing it online, whether they're calling you, whether you get a fax referral from another provider, because we're still using fax in this industry, and then, or whether it's an email inquiry, doesn't matter. That we you get those leads, that means that you've done something effectively through education, marketing, word of mouth. Remember that word of mouth is a very, very powerful. Yeah, let me go ahead. We just got asked to text the link. It's bit.ly/GMRSTURDY2, all caps, or GMRS, all caps. Okay, so anybody inquiring about your services. So what we want to do though is we want to count them. Okay, we want to count those, and we're going to come back to that in just a second, because we want to see what our effectiveness is in the conversion. And in order to convert consistently, you need to have a consistent process. We need to do the same things consistently to get a consistent outcome. Okay, so consider this. This is for all of you, all the providers. Why do you call your dentist? You can put that in the chat if you want to, but why do you call your dentist? You call your dentist to get an appointment. Okay, if you called your dentist and you got off the phone without an appointment, would that be a successful phone call? Right, so that's what I want you to think about. I want you to think about your practice and your business and what's happening in that. So that's the anxiety that patients have. And when we turn ourselves around and think about how our own businesses, our own practices run from a patient perspective, it can provide all kinds of insights. Okay, so what's your new patient intake process, and do you even have one? You probably have one. It may not be written down. What we want to do is start not to script it, but to checklist it. Okay, because we want people talking in their own voice. We want them friendly and conversational. We don't want them reading. Everybody's been through that sales reading the script kind of thing, and it just drives you nuts, right? So we don't want to have them rehearse the script. What we want to do is have a checklist, right? So the patient calls, and if they haven't already given it to us and we didn't capture it, we say, can I get your name and phone number in case we get disconnected? So get the name, your full name, get the phone number, and what's number 3 in the process? Because this number 3, my number 3, is almost never ever done in any medical practice or healthcare practice. So number 3, what did we just say? If you call your dentist and you don't get an appointment, so number 3, we're going to offer an appointment. Now don't freak out, because everybody wants to go, wait, I don't know their insurance, I don't know this. They've already told you why they're calling. They've probably given you the diagnosis. They've probably told you what they need, whether that's I'm coming for my knee, or I saw my ortho physician, or my primary care referred me, or I need to get a cleaning or checkup, or whatever it is. They've already given you some information in the initial conversation. Offer them a time, if at all possible. Now, if there's something else you absolutely need to know, how long an appointment is, or who it's with, or whatever, that you can ask those things. But the point is, I want you to offer them the appointment as early in the process as possible. Okay. The reason for that is that's the anxiety, and we've all called, to get an X-ray or MRI or lab test or whatever, and we end up giving them all of our insurance information and going through all the, the demographic and birth date and everything else, and then the first appointment's in 3 weeks or 6 weeks or 3 months or whatever, right? So we want to eliminate that anxiety. We want to answer their problem, provide them the solution they're calling for as early in the process as possible. Now, one little comment here. This may not be the most efficient workflow for your front desk staff. Okay, we fully acknowledge that. The point is, if it's better for the patient, are we willing to tolerate a little bit of inconvenience on our end? Okay, and if it gets a better result, because this is one way to start standing apart from everybody else in your specialty, everybody else in healthcare, really, because this never happens. And it's something they're not used to. This is a super simple, easy way to exceed expectations. And now the person's anxiety levels are down, their solution, they think they may have the time. And now if you need insurance information, you can get that. Okay, now if you need, whatever else you need to put them in the system, you can get that in order to reserve their time and whatever. But as a patient, I am much more willing to go through all that because you've already solved my anxiety, my problem, okay? So number 6, this one came up from mostly the physical therapy practices, but you can apply it to yours as well. Number 6, and I've given you a link in the handout to to the video and the process, you can go through and you can see what 4 and 5 are. They're not a mystery. Okay, we're not trying to hide them. But number 6 is, what are your goals for coming to see us? Okay, because what we're trying to do is, in the patient's mind, move away from a transactional interaction to a results-oriented interaction. And if I'm starting to think about why I'm ultimately coming and what I'm going to need to do to get my end result, I'm more likely to show up. It's just that simple. Okay. If there are any questions, please go ahead and type them in and we'll definitely answer them. So here's the thing, this is sales, right? We're solving their problem, we're giving them what they need. We know, by the way, we know in that conversation from the diagnosis and who sent them and all the rest that they're in the right place, at least initially, right? We're pretty confident that they're coming to the right place and we have the solution to help them. So that's sales. We want to make sure that we turn that sale thing, the sell thing, from a 4-letter word into something that's positive, right? So now you're going to track and count your inbound leads. Ideally, you do that in your EMR. Okay, so if we're doing the process the way I laid it out, then you're offering them an appointment. Maybe you need, like in a system we needed the date of birth in order to reserve the spot and create a case, right? So name, phone number in case we get disconnected. Great, they've already, Pauline calls me. She's already told me it's for her knee, and her, who sent her, referred her over, and what I'm going to do is say, okay, great, I've got Tuesday at 4 o'clock or Thursday at 11 a.m. And by the way, 2 choices. Okay, that's the other thing. Don't give them a list and don't ask them what they want. People lock up, they're confused. They weren't expecting you to schedule their appointment that quickly, that early. Okay, so give them 2 choices. If the 2 choices don't work, they will tell you, and then you can offer a 3rd or 4th. Okay, but 2 choices makes it simple for them. You're trying to make their experience easier and better. Pauline says, great, I can do Thursday at 11. Awesome. I need your birthday to go ahead and put you in the system and reserve that time. She is now very excited to give me her birthday, right? Because she's getting an appointment, the thing she called for. When I do that, I've now created a case in the system, and you should have a way in your EMR, unless you're on Web PT. Sorry, I didn't mean to take a shot, but there are a couple where it's really difficult to do this. But you should have a report or something in your EMR for cases created. Okay, and when you get the cases created, if you're doing this process and putting everybody in the system and capturing their phone number, their email address, perhaps their information, you have a case and you can count them. Okay, what you're going to do though, that ends up being the number of leads. That ends up being all the people who inquired about your services. Okay, and then what you're looking at is your new patients divided by your inbound leads. That ends up being your conversion rate. And what would be ideal right now is don't change your process. Whatever your process is, you can go ahead and start writing it down. But whatever process you have, go ahead and do this, because we're all about evidence-based business, right? I want you to test it just like you would with a patient. If you're going to do an intervention, you'll test them, you'll see whatever the issue is, intervene, do the treatment, and then retest and see what the result is, right? You're going to do the same thing with your business. So your new patients divided by your inbound leads is your conversion rate. You'll end up with a percentage, whatever that percentage is. You establish your baseline over the course of a month or 2, and then go ahead and change your process. If your process isn't what we've kind of laid out here with the new patient intake process, try that and see what your conversion rate does. Okay, does it improve? But once you've written down and you have a repeatable, consistent process, and then you make changes to that process, you can test and see whether or not it helps. Okay, and when it does, you have a reason to continue it, right? But you can continue to tweak that and improve upon it with new things you learn from whatever source, all right? And think about that with all of your processes, okay? Not just the intake. So to increase your conversion rate, you have 2 options. We just talked about the process that you can alter or change. The other is you can change the player, okay? But one of the analogies I like a lot as a business owner and work with the owners I work with is you're the coach, okay? And you don't need to always be the hardest working player on the field. Okay, there may be a time where you're a player coach and you're doing the activity, but if for the rest of your team, you're their coach and you're not really meant to be doing their job. So as the coach, the things that you can control are the plays, the playbook, your processes, okay, and the players, who's in what position. And you can support them and train them and help them and nurture them and give them the equipment, the items that they need to succeed. But ultimately, your job is to pick people who want to be the best players in those positions, put them in those positions, give them the resources they need, including a really solid process, and then let them do their jobs. Okay, so just a premise there, but you can only really change two things: your process or your players. Now, what else do you sell? Okay, and this will be a little bit different depending upon your practice specialty, but think about a PT practice for just a second. The second thing they sell is the plan of care. Okay, they sell the plan of care because they're going to be coming in for follow-up appointments. And well, we'll use this as the analogy, but the same thing's true. And I was talking to somebody yesterday about a dental practice. Like, why, when you go to the dentist, are they focused on today and thanks and, oh, we should schedule you for a year from now or 6 months or whatever, we'll send you a postcard? Why are we not talking about my next 5-year plan and how I'm going to come, how, whatever the frequency is, what I need to do, what, lay it out for me. Don't hide that stuff, and then allow me to make a decision, right? But negotiate with me, talk with me, and we'll talk about that in just a second. But the hidden problem in all of this is you're not sticky, okay? And what I mean by that is there was a survey in 2018, they haven't repeated it, but almost 7,000 rehab therapists. So this was focused on PTs, OTs, speech, language pathologists. 1 out of 10 patients completes their plan of care. Okay, I didn't get that backwards. Not 1 out of 10 patients doesn't. 1 out of 10 completes their plans of care. Okay, you ever heard a patient say, yeah, PT didn't work for me? Well, no kidding. Because 90% of you didn't finish. So of course it didn't. And if you peel back the onion and really ask questions, it's usually because they didn't do what they were meant to do, or they didn't stick with it or whatever. But why didn't they stick with it? And we have small practices did better. So solo practices did a lot better, but still only 1 out of 4 people completed their plans of care. Okay, and I'm thinking about all the other medical specialties and the training they get, and I'm going to show you what you can do differently. But this can't be a whole lot different for everybody else either, right? I mean, maybe a surgeon, they show up, but are they compliant with the post-op, plan and well, they're what they're meant to be doing post-operatively, right? So if these are the numbers and this is their whole business model, we need to fix this. All right. And I want you to think for a second about what the consequences of that are. Okay, and obviously, revenue, money is a consequence, but I want you to think a little bit differently about it, because what's the consequence to all those patients that aren't finishing, right? That aren't achieving their goals, that aren't getting the result that they bought into, that they came in for? What about your staff morale if they're working with a whole bunch of people who never finish or get better? Okay, what about the effect on your brand? What are these people going out and saying about your business, about your practice? Okay, and then finally, yeah, revenue is an issue, and we're going to make that case in a little while. But the consequences go way, way farther than just, oh, we could be making more money, or we could increase our profit margin, or whatever. It goes way beyond that. So our solution, our diagnosis here is you need to be sticky. But then the question is begged, right? What? How do we do that? What's the treatment? What's the intervention? And again, it's a process. We want to have a repeatable process so it happens across all your providers. Okay. So your new patient evaluation process, first question is, do you even have one? Yeah, you probably have one. Is it documented, written down? Is it consistent and the same across all your providers? Okay, so you need to write it down. Again, we're going to go with a checklist. We're not going to script it. Okay, and we're going to greet them however you greet them. Do you, as the provider, actually walk out in the waiting room and get them? Is that something you do? Or does somebody bring them back and then you come into the room? Whatever that is, it needs to be documented and written down. And if you think about it from the patient perspective, is it as good as it could be? Could it be any better, right? Now, with the clinicians, I'm not going to tell them how to do a subjective exam, right? That's what they've trained for. It's what they went to school for. They've spent years in school doing that, and post, residencies and fellowships and everything else after. This is not the area where they're weak, right? This is not the area where I have to check off and make sure they do it. They're documenting it. So they're going to do the subjective, objective assessment plan, right, in the treatment. What they're not trained to do is have that conversation with the patient. Okay, bear with me 1 second. What we are trained to do is tell the patient, right? So if you think about in school, when you did a clinical practical, maybe another student was the patient and you had a clinical instructor CI there, watching and stuff, you go through the evaluation. At the end of it, the other student gets up and leaves as you're writing your assessment and plan, and you turn to the CI and you tell them what that is, and you pass or you don't, right? Or you do really well, or you get some pointers or whatever. We're never taught to have the conversation with the real person and say, hey, in an ideal world, this would be the plan. This is what we would do to get you to the place you want to be, your goals, right? How does that sound to you? That's your sales process. Would you like me to help you with that? That's your sales process. You're simply getting buy-in and finding out why that ideal textbook plan that they taught you in school may or may not work for that individual. Okay, and their objections come across all different things. So the objections might be, I'm going to be traveling for 2 weeks during that period. Okay, we can shift things a little bit. You're going to have some homework. You can adjust the plan to fit their schedule, right? The objection might be, I've got 3 kids and 2 jobs, and there's no way I can, show up in the middle of the day or do that. Okay, so then we address that objection. The objection might be, I didn't think it was going to take that long. Well, you can explain the healing process and the training and tissue adaptation and all the rest of it, right? Do I really have to be on crutches? Well, yeah, otherwise you might undo the surgery, or you get to have that conversation with the individual. Okay, what about the financial objection? I don't think I can afford it, or I didn't know it's going to be that much, or I've got a big deductible, or whatever, however that is phrased, the financial objection. And the only thing I want to really emphasize to you on that front is if it's a financial objection, figure out how you can address it with a financial solution. Okay, do not adjust the dosage and frequency of the ideal treatment as your first course of action. All right, and when I'm talking with staff, clinicians, and a patient has a financial objection and they immediately want to reduce the frequency and duration or whatever of the treatment plan, it's like, wait a minute, did you write the best, most efficient treatment plan, or did you suggest that? Well, of course I did. Why is that the first thing you'll change? Right? So we want to make sure that we can accommodate the issue and address the objection. And we think about what's our objective in all of this. The objective is to get them to their goals, okay, one way or another. And generally, they have to show up in order to do that, right? So we're going to measure our success. And how do we measure our success in a plan of care? There are a couple different ways, but I'm going to focus on the visits per case number, okay? Because your visits per case, they need to match your plans of care. Okay, so whatever that is. So if you're seeing someone every 6 months for 5 years, well, then you want to know that you have a certain number of visits. If you're seeing someone 3 times a week for 6 weeks, you know what the number of visits are. Whatever it is, you're going to track it in that way, okay? And if you're a surgeon, you're doing post-op, you need them to show up for their post-op visits. So it's a little bit slightly different, but you can still turn that into a visits per case number, okay? And your objective is your visits per case, again, equal your plans of care. So we're not benchmarking against other practices. We're not looking at industry standards because every practice is a little bit different. You're seeing a different set of patients. Your demographics locally, the people who can come to you, are probably a little bit different. The diagnoses and their secondary diagnoses and other issues that they might have might be a little bit different. So what we're looking for is your clinical judgment, which is described in your plans of care, matching what people actually did. Okay, so our visits per case number is our visits divided by our number of new patients. All right, now this may fluctuate week to week and month to month quite a bit. So what we want to do is more of a 3 or 4 month rolling average, and then we get a little bit more sensitive number, because if our new patient number, we have a really busy week with new evals and new patients, then our visits per case number is going to drop and maybe kind of sort of artificially. Okay, if we don't have as many new patients this week, our visits per case number is going to jump up. Well, that's why we smooth it out with a larger sample size. It's just that simple. And then we look at that, by the way, you look at that by provider, okay? And when you do that, what you're going to do first is you're going to establish a baseline, and then you're going to take action. So we establish whatever our visits per case number, and that's a little bit easier because you can go back and pull that information out and look backwards, 3 months, 6 months, and you can do a 3 month rolling average for the past 6 months or something and kind of establish what that is. You've already got a record of that one. The conversion rate, you may have to start tracking your leads, because in my experience, most providers are not tracking their leads ahead of time. Okay, so that'll be a process that you'll need to implement. By the way, what's the other reason we want to track leads? Pauline, you want to jump in here?
I want to make sure your marketing is effective, if I know from
Yeah.
our client's perspective. Yeah.
Yeah, exactly. Lead generation is a lagging indicator of your marketing effectiveness.
Mm-hmm.
Okay. So if I establish a baseline, let's say you don't have any kind of marketing program going on right now, and I know the number of leads. Well, when I hire GMR, or I start doing social media, or I visit a couple, primary care physicians to refer, or whatever it is, I can then, just like my treatment, test, have a baseline, do whatever I do, the intervention, and then look at the result. Okay, we want to be analytical about this stuff and not kind of go back to the old school idea of, we'll throw spaghetti at the wall and see what sticks. we want to test it and see and make sure it's working and that we're getting a return on our investment, whether that's time, by the way, whether that's time and effort or money or a combination of all of them. Your time has value as well. So even if something's quote unquote free, but you're spending a bunch of time on it and you're not getting a great result, you may want to rethink that and look at how that works too. Okay. So this is another question. As you establish your baseline and you look at what we're going to look at next, what are the potential improvements that you could make? What's going to be more impactful for your practice? Because again, every specialty, every practice, everybody's a little bit different. So we want to just, by the way, just like your patients. Right. So we're going to look at that and say, well, is this the right order? Should I be looking at conversion rate first? Can I, what are we going to get? What's going to get the biggest payoff for the least amount of effort? Okay, that's how I prioritize stuff in my business. What's going to give me the biggest payoff for the least amount of time, energy, money, effort put into it? Okay. So I want to give you a couple examples and then just take a look at this. So if you'll think about a physio practice for a second, you can, or really any practice on this front, sorry, the conversion rate. If I increase my conversion rate, I did my math wrong, 74 to 78, not 75. Oh goodness. Okay. Well, let's say we increase it 4%, because that, actually that is a 4% increase. Sorry, if you divide 75 by 78, it's a 4% increase. And then this one, the 78 to 84%, that's a 7.692 increase. Okay, what happens if I increase my conversion by that amount? Okay, hold that, think on that for a second. What if I have my visits per case? So if I'm a typical ortho physio practice and I even have small changes, okay, remember we said like 90% of patients aren't finishing their plans of care. So the potential changes here are really could be huge, but you have to figure out what your current visits per case number is from your EMR, and then you can go and look and pull the evaluations and figure out what your therapists, your clinicians are actually writing for the plan, and you can compare those two. So a 10 to 10.4 visits per case increase is 4%, right? 9.6 to 11.1 is a 15% increase, right? My question for you in both of these cases is, did you spend any more money? Right? So if I increase my visits per case by 4%, my revenue increases by 4% with no additional expense. Okay, if I increase my visits per case from 9.6 to 11.1, and that's because they're supposed to be showing up for 11.1. We're not writing different plans of care. Okay, there's a gap there. But if I increase my visits per case by 15%, that's a 15% increase in revenue. All right, with again no additional expense. Those people are already there. All my costs are sunk. This could be your entire profit margin potentially. Okay. So I want you to think about your return on investment from putting forth the effort, because you don't necessarily have to spend a bunch of money to get this done. Okay, you might hire somebody like me and get it done, but that's going to be the extent of your expenses. You're not spending more money. You already have the staff. You're establishing a process. You're reviewing the process. You're making sure it works, and you're looking at the improvements that you get off that process improvement. And your increase in your conversion rate and your increase in visits per case, and you can think about other things that might apply to your practice. Those are all increases in revenue because there's no additional cost involved. Okay, so what's 4% of $1 million, right? What's 15% of $1 million? So if you have a practice that's generating around $1 million in revenue, and you can scale this up and down linearly, right? So if you have a $500,000 practice, it's going to be half. If you have a $4 million practice, it's going to be 4x. But 4% of $1 million is $40,000. Okay, 15% is $150,000. So, and again, no expenses, right? So if you do this, and I've had people go, well, yeah, I don't know. Okay, maybe you don't. Go home and talk to your significant other, okay, and or your kids or whoever is important to you, and ask them, hey, if I implemented 2 processes, then I could potentially make another $80,000 a year, and help more people and get more people to finish and get to their goals. Do you think I should do that? Right? What's their answer going to be? Like, yeah, what help do you need, or why are you here? Go back to work, or what, whatever it is. But this is, they're not going to go, well, I don't know, right? So think about that for just a second, and see what you might do about it. And you've got this on your worksheet. I just want to talk about it real quickly, because most people, when I ask, what's your profit, their answer is whatever's left over. And I really, really, really want you to get out of that mindset. Okay, you begin with profit. So you think about whatever, you know what your cash flow was last year, okay? What I want you to do is not worry. You can do a baseline, right, of what your current profit was. You've got 2 other buckets. Your 2 buckets for expenses are your overhead expenses and your personnel in this type of business. If you run a cafe, or you're making slings or something, then you've got a COGS, a cost of goods sold. That's a 4th bucket. But for a service business, that's generally not very big at all, if it exists, if it even exists. So our overhead expenses are all the fixed expenses. They're all the things that would not go up and down with hiring people. Okay, so write that one down. They're all the items. If I pull out my QuickBooks and do all my categories and line items, it's all the stuff that won't go up if I hire somebody. It's all the stuff that won't go down if somebody leaves. Okay, so your rent, your utilities, your internet, you name it, all that stuff that isn't going to fluctuate is your overhead. Everything else aside from your overhead and profit is personnel related. Because if it goes up and down when I hire someone, okay, even if that's an outsourced billing expense, it's going to go up because when I hire someone, the revenue is going to go up, and then I'm going to pay more there. So it's related to personnel. So it's not just wages and benefits, okay? It's also the taxes, it's the work comp, it's the software licenses, it's the billing expense, it's all those different things. So really the easiest way to look at your personnel expense is to subtract your profit and your overhead from your cash flow, okay? And then that'll give you, basically, put it this way, if you set your profit target, let's say you set a 15% margin or a 20% margin as your target, you have a 25% overhead. That gives you 45%. You have 55% left for all of your personnel expenses. And then you can categorize and compare your budget and see if you're on target. And you can see where you can change it. But the big deal here is it's really difficult to cut expenses in a business unless you just have a bunch of waste or things that you've been spending on that aren't effective. You're going to get to you can cut your expenses maybe somewhat on the overhead, but not a lot. And it's really hard sometimes, because is your landlord going to accept less? Can you reduce your mortgage expense or whatever it is you're paying there? Is your internet, can you reduce the cost there? And sometimes there's a little bit to be had, but generally it's pretty low. Is your staff going to take a salary cut? Probably not, right? And if you're thinking about, well, I'm going to negotiate my billing expense down, if they're doing a good job, they're paying for themselves. And when you give a disincentive to the people running your billing and revenue collection, that the results may follow. So be careful about what you try to cut on the expense side. And that's why we're so focused on the revenue side. Because what I see in essentially every healthcare practice I look at is there is low-hanging fruit on the revenue side that is not being collected, okay, and not being run efficiently and not taking advantage of. And a lot of times that ends up negatively impacting the patients as well. So it's not, that's the beautiful thing about this whole industry, is generally if you're doing the right thing by the patients, you will do better financially. And just want to leave y'all with, created this book, and we're working on the private practice edition as well. And it's got a bunch of this stuff in there, as well as a lot more on the foundational things. And I'm just showing you this. So if you're interested, please reach out and email me. And if there's anything I can do to help you, please go ahead and reach out and email contact me as well. And then that's where we swipe some of the photos and stuff. So what questions? Do we have anything else that's been asked in the chat or come up, or do we want to unmute folks?
Feel free to enter your questions. Sturdy, I had one for one of my clients. Just curious, because I know maybe it relates back to how they're selling the care and like the, how the front desk is handling scheduling appointments. But one of my clients, she struggles a lot with broken appointments. So, they come in, they kind of don't show up, and then they try to reschedule, and it's like causes a lot of extra headache for the staff. So I'm curious, maybe that's to do with their intake process and things like that. But I'm just curious with your perspective on that.
Well, it could be, it kind of depends. Is it a first appointment? Are these first appointments, or are they follow-ups?
First appointments.
So if they're first, then I would look at that intake process and figure out what's going wrong with it. Is it that the benefit, are they calling back with benefits that were unexpected, or there are all kinds of little things that can go wrong along the way. But one of the big ones is tying their goals in that initial phone call. Why are you coming to see us? Great. And then reassuring the patients that, yes, that is what we do. That is what we can help you with. And, the other thing is, if it wasn't, I'd be referring you to someone else, right?
Yeah.
So, when they call, I owned a PT practice for over 20 years, right? So if somebody called and said, do you help people with knee arthritis? Like, absolutely. Who's your doctor? Dr. Chen. Oh, we do a lot of work with Dr. Chen. He's awesome and we're happy to see you and get you in. You're just reassuring them that they're in the right hands in the right place. And it's little things like that. And that's where you really have to see the process. You have to see the written process. You have to watch people, by the way. Think about your coaching hat as a practice owner. Put your coaching hat on. If I'm a little league coach and Jimmy was meant to be working on his batting, over the last week, and he comes to practice and I go, hey, Jimmy, how's your batting going? It's going great, coach. Is that where it stops?
Yeah. No.
Right? It's never where it stops. If you think about your patients, it's not where it stops. You go, okay, get in there and show me, right? We don't do that with our staff. Why not? Right? How's it going with the intake process? It's going great, boss. Okay. And you walk away. No, stop that. Okay, can you take me through it?
Yeah.
What? And this is a little bonus for you guys, right? You'll get one of three responses, okay? One of three responses to show me, okay? You're gonna get an enthusiastic, yes, I'm eager to show you. Everybody knows that's great. You're gonna get a reluctant, evasive, again, think about your patients. Have you been doing your exercises? Yeah, they're going great. Okay, can you show me? Well, okay, what's that mean? It means they haven't been doing them, right? Or they don't know. So you're gonna get that evasive response. Okay, that's negative. We want to correct that. The third response, though, is really ambiguous, and it's the ambiguous answer, right? It's the apathetic, like, okay, that's actually a positive response. Okay, and the reason it's usually a positive response is they don't see the point in showing you because it is part and parcel of the job, and they've been doing it, and they're confused as why you want to watch it. Right? But that's okay, because that means they've been doing it. So don't confuse that one for a negative response. But I haven't, if y'all come across a different response to, okay, great, can you run me through it? Can you show me? Can you, can I watch you or something? If you have a fourth or fifth different kind of response there, let me know, because I haven't found them yet, right? You're gonna get one of those three. Just remember that the kind of apathetic, confused version is not necessarily bad. It's probably positive, because they just assume that's what they're supposed to be doing. Well, yeah, that's the job, right? And that's not a bad thing. Okay, but you still want to watch it. You still want to see them, and then you want to, recognize them for the good work they're doing, or help them out to do a better job.
Perfect.
Is that useful?
Yes, totally.
So for those who are here, I allowed you to unmute yourself. If you have a question, you're welcome to just say so. And if we don't, that's cool too. You can always follow up with me. Pauline has info. My email's super simple. It's sturdymckee@gmail.com. or Sturdy at sturdymickey.com. And you've got my website down here, Sturdy Coaching. And if you just Google Sturdy McKee. Cool. Well, thank you, Pauline. Thanks so much.
Yeah, thank you so much, Sturdy, for your time. Like I said, I'll, provide the webinar recording. It should come one day after this recording, but if you would like it sooner, definitely you can get in touch with us and we can send it over. Again, thank you so much, Sturdy, for your presentation.
Wonderful.
It's super helpful.
Okay, thank you.
Perfect. All right, thanks everybody.